Welcome to the NeuroPace community chat featuring Jason Schwalb, MD. My name is Allie, and I will be your operator for today's call. At this time, all participants are in a listen-only mode. Later, we will conduct a question-and-answer session. Please note that this conference is being recorded. I will now turn the call over to Janet Greenwood. Janet, you may begin.
Thank you very much. I'd like to welcome everybody to the community chat. I'd like to introduce Dr. Jason Schwalb. He is a board-certified neurosurgeon from Henry Ford Medical Center. He did his surgical training at the University of Pennsylvania and Johns Hopkins and his fellowship at the University of Toronto. Today he will be speaking about his experience with treating patients with the RNS system and providing some information. And then we will also have a patient who is currently being treated with the RNS system, Carlo, also speaking. And then we'll open it up for questions and answers, and Dr. Schwalb will answer those questions. We do ask that you limit your questions to just one question, just so that we can make sure that everybody gets an opportunity to ask a question. We thank you all for joining us, and I'd like to turn it over now to Dr. Schwalb. Thank you.
Great, thanks so much. And if people would just write down their questions as they think of them, and then you'll remember them as we open up the phone lines in about half an hour for questions. So I'm the surgical director at the Comprehensive Epilepsy Center at Henry Ford Health System. There's a national association of epilepsy centers, and different epilepsy centers around the country are rated based on the services they provide. So you can have lower-level centers that provide EEG or video EEG and epilepsy specialists, and then higher-level centers like ours that provide all sorts of surgical services, including placing electrodes to try and figure out where the patient's seizures are coming from. And I have a pretty broad practice. I do a number of different things other than epilepsy, but epilepsy is really one of the things I'm most passionate about, because I think it's one of the things that, as a surgeon, I make the biggest difference in people's lives. And just to give you an idea of sort of the size of the problem, there was an Institute of Medicine report published in 2012 that showed that basically there are 1 million Americans with what's called drug-resistant epilepsy, or these are patients with epilepsy with seizures that do not respond to medications. And the data sort of suggests that there are between 100,000 and 200,000 people with drug-resistant epilepsy who might benefit from surgery. And we know that if we choose the right patients, we can make them seizure-free. With a patient with a very specific type of localization-related epilepsy, where we can figure out where the seizures are coming from and either take that part of the brain out or burn that part of the brain, we know that we can add 8 years onto a person's life. And I think part of the message is get people who are treated, who don't have the best seizure control, to an epilepsy center where surgery can make a huge difference. And, I think a lot of what we see, and we see this across the U.S., are patients who have had seizures for 10, 20 years before they ever make it to an epilepsy center. And yet we know that we can have a huge impact. And most people will do fine, with their seizures, and about 2/3 of patients will do well with the first or second medication that's tried, that's appropriate, that's brought up to the right dosage. But after you fail 2 medications, if you're still having seizures, and that means like any seizures with alterations of consciousness where you're not really aware of what's going on, the likelihood of a third drug or some new combination of drugs bringing your seizures under control is only 4%. And that hasn't changed in the past 20 years with the introduction of 10 or 15 new seizure medications. And we know that people with seizures, have, especially certain types of seizures, are really high risk of sudden death or trauma related to their seizures, especially if they have generalized tonic-clonic seizures. So there's a paper that actually just came out the past month or two that looked at this, and if you have more than 3 generalized tonic-clonic seizures a year, your risk of dying from sudden unexplained death of epilepsy, or SUDEP, 1.8% per year, or 18% chance of dying from your epilepsy over a decade. And that doesn't include, falling down or hurting yourself or trauma or drowning. So the real number is probably around 20-25% of patients have a risk of dying in a decade if they're having more than 3 tonic-clonic seizures a year. And so I think we need to be much more aggressive with surgery, when we have a number of different technologies, be it taking out the part of the brain if the person is a candidate like that, where we can really cure patients, or things like RNS from NeuroPace, or even vagus nerve stimulation, both of which have really been shown to reduce not just the frequency of seizures, but also the severity of seizures, and reduce the risk of SUDEP, and that's really what we're looking for. And the only way to really tell this, what sort of candidate surgery someone might be is to come in and have a video EEG where you're admitted to the hospital and the medications are lowered until we can observe seizures. And then based on that and MRI and neuropsychological testing and a number of other different techniques, we can hopefully figure out where the seizures are coming from. In some cases, like Carlo's, who you're going to hear from, we really weren't sure where his seizures were coming from, and the EEG just didn't give us enough information trying to record seizures through the muscles at the side of the head and through the scalp and all that, and sometimes we put electrodes either on the surface of the brain or in the brain, and we have new techniques for that are much safer than the older techniques, and that's what we did for Carlo. And, in his case, as he's going to tell you, it seemed that his seizures were coming not from one area of the brain, but from 2, and it really wasn't safe to take those out. We would have hurt him and made him not Carlo. We would have really impaired his ability to form new memories had we tried to take both those areas out of the brain. So in this sort of situation, we have this great option now, which is RNS, which is essentially like a demand pacer of the brain. And the general idea is that you can figure out where the seizures are coming from, or an important node by which seizures are spreading through the brain. You can put an electrode there and a small computer, a miniaturized computer, that will detect seizures. And then over time, you can program it so it can learn to even better identify seizures. And then when a seizure is detected, it sends an electric pulse the other way and can stop the seizure before it spreads or decrease the severity. And we were a center in the initial trial, many years ago, and that showed, success, and that was FDA approved now, I think, about 3 years ago. And there have been over 1,000 people who've been treated to date. It's really available at most of the comprehensive epilepsy centers in the U.S., over 110 centers that are offering RNS. And because of the results from the pivotal trial, it tends to be covered by insurance, and we don't really have a lot of trouble with coverage. And even those with whom we do have problems, I'm on the coding and reimbursement committee for organized neurosurgery. We've been pretty successful and sort of appealing and showing that the medical evidence is there, that this can make a big difference in people's lives, and for the insurers, we're even able to show that it can reduce costs to them. So just in terms of how much it helps, this is not a technology that's likely to make people seizure-free, although, many people can get, 6 months at a time where they're seizure-free, up to 30%. They can significantly reduce the frequency and the severity of seizures. And in the initial trial, which we really looked at only about 6 months, there was definitely significant improvement over people who didn't receive the stimulation in a blinded fashion. But not surprisingly, as we're able to learn for each individual patient what the signature of their seizures are, we're able to refine the programming and do a better job over time. So, we have a number of patients that we're still changing their batteries on, when their batteries run low. When you're looking at 7 years out, most people are having about 70% reduction in their seizure frequency. And about a quarter of these patients are having a seizure reduction of over 90%. And I think the biggest telltale sign for this is that, the patients are not having their systems taken out. I mean, when that battery gets low, they want it replaced because it's made a huge difference. So this isn't as curative as, in those cases where we're able to take out that part of the brain or do laser ablation of that part of the brain, but can be very effective, and it makes a huge difference in terms of quality of life. And a lot of patients, about 30%, report that they do have intermittent periods of seizure freedom that can last as long as 6 months, but the vast majority are not seizure free. That being said, people don't have a lot of side effects from this. They don't feel when the stimulation is going off, and their thinking tends to improve, their quality of life improves, including their mood, their mental health, their thinking, and their concern about their seizures. And in fact, there is some evidence that the risk of SUDEP, or sudden unexplained death of epilepsy, is also significantly reduced. And I don't know if you heard this bit before, things got cut off, but it seems to be better over time as we do a better job figuring out the signature of the seizures and can adjust the programming accordingly. And I think the biggest way that I've been able to see success of this technology is that early on when we were doing the trial, we had some issues where we had a couple of wound breakdowns. I wouldn't be concerned about that now. We haven't had problems in over 5 years. But the patients who we had to take the system out because it got infected or their skin broke down, and those patients wanted the system put back in as soon as possible. And patients where, when their battery runs out, usually somewhere between 3 and 5 years after its placed, they're desperate to come in and get it replaced as soon as possible. They're very worried about losing the benefits. So it can make a really huge difference in patients. There are some limitations. Right now it's FDA approved for only patients over the age of 18. These are patients who have failed at least 2 medications. It really only works if we can identify where the seizures are coming from. And the way the computer is set up, if the person has one seizure focus or 2 seizure focuses foci, you're fine. But if there are 3 or 4, the computer only has channels for up to 2. And patients still do need to continue on their medications since it doesn't cure surgery. But we've found it to be, very, very successful in patients where we can figure out where their seizures are coming from. So now I think we'll move on to Carlo, and I don't know where you left off, but I'll let you talk about sort of your story and what we all did to you and what the results have been.
Well, hi there. My name is Carlo, and I've had epilepsy for 28 years. Epilepsy started out for me when I was 6 months old, and it was caused by a fever. My childhood was sprinkled with periods of activity and inactivity. For the most part, my seizures were controlled with medicine. In college, after being seizure-free for 5 years, I was weaned off my anti-epileptic medication. I felt free. About 6 months after graduating from college and starting my career, I started having complex partial seizures that originated from both temporal lobes. During this time, my seizures got progressively worse and more frequent, despite trying multi-epileptic anti-epileptic drugs. I would have clusters of 3 to 5 seizures at least once a week. On bad weeks, I'd have up to 15. These episodes impacted my ability to function in everyday life. I found myself constantly waiting for a seizure to occur. These seizures were not controlled by medicine. So after about 1.5 years of trying to maintain productive life while dealing with uncontrolled seizures, my neurologist referred me to an epileptologist at a level 4 epilepsy center. The first meeting with the doctor was overwhelming. He started with a statistic that after the third anti-seizure medicine, any additional medicine has a less than 5% chance of being able to manage seizure activity successfully. I was already on my fourth medication. He then informed me that my best chance of becoming seizure-free was to consider surgery. I was leaning towards a lobectomy with the hopes that my seizures would go away completely. At the end of testing, my epilepsy team decided that the RNS system would be the best option for me because my seizures originated from two places in my brain, both of which were my memory centers. If we were to do the lobectomy, I may have lost portions of my memory. Prepping for the RNS surgery did not really put too much stress on me. Honestly, I was more nervous about my wedding 3 weeks later. The surgery was pretty quick and successful. I was able to return home the next day. It baffled me that I was out of the hospital within 24 hours of having a brain surgery, but I felt pretty good. The RNS system is very easy to use on a daily basis. I almost forget that I even have it in. If you were to touch my head, you'd barely be able to notice the device since it sits flush with the skull. My scar isn't noticeable since my hair's grown back. And if I didn't tell anyone I had the device in, they wouldn't even know it was there. The RNS device is working around the clock to monitor, detect, and to detect the seizure activity in my brain. I've never felt the device activate for a seizure. It is constantly collecting data and notes where my seizures originate from and what times of the day I present with more seizures. RNS system data is helpful when going to the doctor appointments because together we can make informed decisions on changing stimulation parameters on the RNS device to better identify and prevent my seizures. We have also used the RNS data to make decisions on when I should take medications. When I have a seizure, I'm able to use a strong magnet with the RNS device to timestamp the seizure activity. I don't have auras, which makes this method of marking difficult for me. If I'm at home with my wife when a seizure occurs, she'll timestamp the event with me with the magnet. If we're out or I'm at work and a coworker tells me I had a seizure, sometime after the event, I can manually mark it on the My Epilepsy Diary website. The RNS system works very well for my family and I because it's always collecting data on my seizure activity. And let's say in 5 years, RNS data shows 9% of my seizures originate from one location, the lobectomy could be a viable option for me. For another scenario, let's say something more effective comes out to control seizures 5 years from now. My device can be removed with no damage to myself. It is reversible. One of my favorite things about my device is going to the doctor and comparing the amount of seizures I've noted and how many I've actually had. Some months are worse than others, but being able to experience the months with 1 to 2 seizures makes the whole process worth it. Every night I take time to download my data, which only takes a few minutes. Then about once a week, I upload the data I've collected all week to the database. Pretty simple. Growing up, everyone has their own goals to achieve. My plans were to get married, start a family, be successful, and live a happy life with a happy family. Well, I thought all that went out the window when my seizures came back. I thought since I was unable to drive, I was going to lose my job. If I was not able to drive, then where was I going to work? It really started to stress me out. I was a prisoner to epilepsy. I was always anticipating a seizure. There was never a moment that epilepsy wasn't my first thought. I've been relying on people for transportation everywhere. I had to get a ride to work, a ride to the store, or to wherever I needed to go. I used to be absolutely terrified of having any activity around people because it's embarrassing to me. My seizures make me look like a crazy person to someone who doesn't understand what a complex partial seizure looks like. People would not let me go off and do anything by myself because they didn't want me to have a seizure around someone that I didn't know. I was afraid of losing my job, and I was being babysat on a daily basis on everything I was doing. I really didn't have a social life anymore. The RNS device has been a complete life changer for me. Instead of sitting around waiting for the next seizure to pop up, I can go out and live my life. I've regained my freedom. My memory has improved since, and my seizures have reduced in severity. I got married 3 weeks after my surgery, my beautiful wife, returned to work, and now have a newborn daughter. NeuroPace has helped me return to work in a modified setting. It's very hard for me to open up to my colleagues, but now that they know about my device and my seizures, they can inform me when I have an episode, and we can move on with our day. Before my daughter was born 4 weeks ago, I was worried about having a seizure while holding her. Before getting the RNS system, I would not have been able to safely hold my daughter or take care of her by myself due to the frequency of my seizures. I feel much more comfortable now knowing that the device has been working so well. Besides having the RNS device placed, we've made some other life changes to help improve my quality of life. We moved close to my office so I can walk to and from work every day. This helped me establish my own schedule instead of working around my family and my friends. I feel confident that I'll be safe when going out by myself. We've also made a conscious decision to accept our new normal, which is doing almost everything together. Our normal may not be conventional, but it works well for us. I've also made an effort to see the positive side of things instead of focusing on the negative. My journey with epilepsy has brought my family closer together, my relationship with my wife stronger, and improved my outlook and appreciation for life. Looking back at the goals I've set from a young age, I can check them all complete. I've graduated college, got married, started having children, I'm successful, living happily with my family, I'm looking to a happy future with them.
Thank you, Carlo. That was very inspirational. I'd like to now open it up to questions from the audience. Allie, can we go ahead and take the first question for Dr. Schwalb and for Carlo?
Of course. And our first question comes from Dennis S. Please go ahead.
Yes, thank you for putting this on. And Doctor, are you associated with NeuroPace in any way?
I have not. I've never received any personal payment or speakers bureau. You know, my institution did receive money when we were part of the trial, but I never received any direct payment.
All right, good. Well, they have their ambassadors, but their ambassadors it always seems like it's just another marketing program. So, thank you.
I mean, I think the data speaks for itself. And, you know, in NeuroPace, just like any other company, isn't going to have you speak to patients who had bad experiences. But the reality is that, you know, we've treated a number of patients, and, you know, even the ones who've had problems where we've had to take out their device because they had an infection or something like that, they come back and they want it back because it really helps. And they have a patient that's flying up from Florida in the next week or two to have her battery replaced, and she's had the system for 7, probably 9 years. And at one point, we had to take it out and put it back in.
Thank you. Can we move on to the second question, please?
Of course. Our next question comes from Donna M. Your line is open.
Yes, I just had the NeuroPace put in March 6th up in Grand Rapids. And my question is how long do you have to keep sending information to your doctors for the rest of my life? Or is there a time when it will be stopped having to be sent?
I mean, I think the best, I'll defer to the NeuroPace execs, you know, if they have some other ideas, but, you know, in our experience, in most of our patients, it's a lot more intensive the first year or two as we're trying to get the best settings, and then I think it depends as to, how low we're able to get your seizures. Obviously, the batteries don't last forever, so you're always going to need to have those dealt with, every few years. But, it is sort of a lifelong commitment. That being said, we do have patients that they're not downloading every day. We have one patient in the community who's Amish, has no phone, has to go to the local Kinko's and, hook up and download his data. and doesn't do it that frequently, but it's still, and I don't think he's going to have a good result as someone who's able to download frequently and work closely with their neurologist to optimize the settings, but it's still helping him.
Yeah, and this is Janet from NeuroPace. Just want to add that, the value of the data is that it allows your epileptologist to learn a lot about your epilepsy beyond just what you report clinically from your seizures. So it gives them insight and into what's happening in a fashion that they would never had available before. So although most patients find that, initially, just like Dr. Schwalb said, we do ask you to, download the information a little bit more frequently. It's because we're trying to learn kind of your thumbprint, your fingerprint, and what your seizure onset looks like. So it's really important that your doctors get that information. But over time, really what we're doing is making sure that the device is, checking the battery status, making sure that, we're looking at the signals. And then obviously, we want to just kind of keep an eye on different trends, and that data becomes available when you provide it to your doctors. And we know that the technology gets better over time. So we know from year 1 to year 2, year 3, that we're continuing to improve, and we can constantly kind of gather that data and make improvements to your device. So most patients don't find it, and hopefully you won't either, maybe Carlo can speak to this, don't find it burdensome to do the downloading. Carlo, do you have insight into that?
As for downloading,
yeah.
I just take my wand before I go to bed at night and let it download for a couple minutes, and like I said, about once a week, I upload to the database and dump about 7 days worth of data up there instead of dumping 90 days worth of information for the doctors. So, it's pretty simple. It's pretty easy, and it's not that big of a burden for me.
Okay, great.
It's not a problem at this point. The problem I have is that hooking it up to like the router of the TV, and I am not a computer person. And then this week, actually, the NeuroPace was going through a routing of it or something in that, and I couldn't get it to work, and I had to call them, and it turned out that they were rebooting it, kind of a thing.
Yeah, so we were actually, so that's a good point. We actually were updating the system and making improvements to it. So, we apologize if it caused any inconvenience. That's right. That's a kind of a one-time kind of situation. And I apologize that you have to connect to your TV router. I know it may be, you have to unhook things. Yeah. There are kind of systems where I think that you can actually put in two different things and like connectors. So maybe we can work with you and to help you with that to make it a little bit easier. But hopefully you'll find that, it's not too much of a burden.
Right. That was the only problem. And like if we're not at home kind of a thing and doing that kind of a system if we're out of town, that kind of a problem is doing those kinds of things if it was going to be used. Stuff.
Yeah, so usually what most physicians will say to their patients over time is that when you go on vacation, you should go on vacation and not, you don't have to bring the computer with you. We want to make sure that, if you're 3 months out, 6 months out, a year out, your doctors have a good idea of what your seizure onsets look like, and the device is kind of already doing what it needs to be doing. So we want you to go ahead and enjoy your vacation. So talk to your physician about it, but we certainly don't want to burden you when you go, you're traveling on vacation, that you have to bring the laptop with you.
Yeah, and even I was supposed to go last week to see the doctor from having the surgery last week and couldn't go because of you guys rebooting it, redoing all this stuff.
Yeah, no, so again, we definitely apologize for the inconvenience.
Oh, yeah.
And yeah, so hopefully that, that was just a one-time thing, and we're making upgrades to improve the system. So hopefully those upgrades, I think your physician will like, and I think you'll like seeing some of the, make sure you ask your doctor to show you some of the new updates. I think you'll really like seeing it. Okay. Let's go ahead and move to the next question, please.
Right, yeah.
Thank you so much.
And our next question comes from Carol R. Please go ahead. Your line is open.
Hi. I had a question for Carlos. He said that people can tell when he has a seizure, but I wasn't sure. I thought the RNS I thought that was kind of like the point, so people didn't know. So that was just, I just wondered how that worked.
Well, I mean, in my case, I'm still having a couple seizures here and there, but not to the frequency where it was a year and a half ago, 2 years, where I was having clusters of 15 to 20 seizures a week. Now I'm having maybe 2 a month. So.
Oh, okay.
So, I mean, my seizure count has gone down about 90% from when I've started, and it's purely because of this.
Oh, so are they're not just orals? Are they like
I've never had I've
okay.
never personally had an aura for a seizure. I don't know when they're coming on.
Okay.
I get told after the fact, or I realize I just had one.
Oh, okay. Oh, okay, thanks.
Okay. Can we have the next question, please?
Our next question comes from Dennis S. is back on with a question.
Yes, hello. Doctor, I was wondering, what's your feeling if a patient has a VNS system already, with what's your feeling with the RNS system?
It's not a problem. Even as in the initial trial that we participated in, patients were allowed to have VNS systems. So we haven't had any major problems in terms of interactions between the two devices.
So leave it on at the setting where it's at was what you would do?
Yeah, I mean, I think, people should get the benefit of both devices. I don't think there's any evidence that one interferes with the benefit of the other. It's probably additive. But Janet, have you guys had any other data on that?
Yeah, so we have, in the commercial, since our approval, we have about 150 patients that are being treated both with the RNS and the VNS system. And as of to date, we haven't observed any adverse events or any interaction between the two systems. And we're thinking, or at least hypothesizing, that the two systems may work well together. So we're still looking at that, but they seem to cohabitate and kind of play in the sandbox well together. So many physicians will opt to continue with the VNS therapy, and then also, if appropriate, implant the RNS system and then treat the patients both with both systems. So it definitely is not something that if you do have a VNS that you can't have an RNS system.
Well, it's good because that's what I originally I was looking at the RNS and ended up settling for the VNS, and now we're testing for the RNS again. And I'm hoping that we can both play well together. And so, and as far as Carlo with his holding his child, congratulations, because I have grandchildren, and that's one of the goals for me is to be able to hold my grandchildren without that fear of having seizure and having the grandchild get hurt. So, thank you very much for your time.
Thank you also for your questions, and good luck with, your evaluation for the RNS system. Okay, can we move on to the next question, please?
Our next question comes from Carol R. She's back on with a question. Please go ahead. Your line is open.
I'm sorry, I wanted to ask one more. Can I ask two?
Sure, go ahead. Then no problem.
Okay. Okay. I was like, I wasn't sure if I should keep dialing in. Okay. I think Dr. S mentioned there was a wand for the VNS or the RNS, and I wasn't sure if the wand was like kind of like the VNS, like when we get a checkup, or if it was a wand that's like the magnet. I wasn't sure if he meant the magnet or like the type of wand that they use when we have to get a checkup.
It's a little bit different. Yeah, it's a little bit different. So, in VNS, there's a standard, and it can vary from programming neurologist to neurologist, but it's a standard way the device is programmed is that it's on for 30 seconds every 5 minutes. And then if the person feels neuro or someone sees them having a seizure, they can swipe the device with a magnet and it will deliver an extra pulse. With the RNS, it's a little different. The RNS, swiping it doesn't deliver an extra pulse, but it tells the computer when you had a seizure. Because there are seizures that are obvious electrically to the computer, but it's not like the computer has a camera or has some other way of telling when the patient is having a seizure other than the electrical activity. So it's helpful to have the person swipe it and it basically sets off a little timestamp and makes sure the computer saves a certain amount of data to be downloaded later to the programming neurologist.
Oh, okay, thank you. I wasn't sure because I have a VNS now, so I wanted to make sure that it wasn't doing it. They didn't do the same thing.
Okay. Next question, please.
This is Russ from Epilepsy Foundation in Michigan. I had a couple questions from someone who was not able to be on the call. One was if the magnet is not used when a seizure occurs, is that seizure then not recorded and provided to the doctor?
So I can answer that question. So, yeah, there are different ways to store information from the device, and one of the ways is with the use of the magnet. But the device has different abilities to and different ways to store information. So we can store seizure events other than by using the magnet, because we know many patients lose awareness during a seizure. Correct? So we usually recommend that those patients perhaps don't need to use the magnet because they may not remember that they had a seizure. So we have other tools within the device that allows the device to store that information. So you shouldn't, whoever you are answering the question for, they should not be concerned that the device won't pick up or won't store that information because we have other tools to do that.
Got it. Great. And then the other question was, how significant is the surgery to replace the batteries? You said it happens about every 3 to 5 years. Is that an outpatient surgery, I assume? How long does it take?
Yeah, so it is. It is an outpatient surgery, and the way it's set up is that the battery kind of splits into this tray. So it's pretty straightforward to take it out, put it back, reconnect the wires and put it back in. We do it as an outpatient. I tend to do it under general anesthesia just to keep the patient comfortable, especially when you're working on their head. But it's essentially about a 30-minute procedure, and the patient goes home an hour and a half later.
Yeah, I usually, it usually takes you longer to check in when you're checking into the hospital than the actual procedure itself. Just getting through admitting is longer than the actual procedure usually. So it's, just like Dr. Schwalb said, it's an outpatient procedure, and the majority of patients go home the same day.
Okay, and then one more question was, with the wand being able to, the device being able to be programmed remotely via the wand, and are additional visits to the doctor necessary? I mean, are you going to have more doctor's appointments, at least initially, and then long-term are you going to have to visit the doctor more often? This person's in a somewhat remote area and is concerned that he would have to have more doctor visits.
Yeah, I can go ahead and answer that question. So the device, first of all, the device cannot be programmed remotely.
Oh.
We can get information from the device remotely, and that's what the patient uses to download the information and send it to the physician. But the patient doesn't have the ability to make any changes to the device. The doctor can then look at that information in their office. Most epileptologists routinely see their patients because of the type of epilepsy. They're refractory, meaning they're the ones that are not being helped by medication, usually every 3 to 4 months anyway. So there would not be an increase in the amount of visits that the patient would have to come back. Now, immediately post-op, usually the surgeon obviously is going to want to see the patient, and Dr. Schwalb can answer that part, but it's usually at 2 weeks or 1 month. And they usually try to coordinate it so that the epileptologist is seeing the patient at the same time. Now, the surgeon may want to see that patient again in the next month, and usually they'll coordinate. So the first 3 months, the patient will get seen once a month, and then after that, it's every 3 to 4 months. And then after a year, it can be extended out to every 6 months. If the patient's doing great, it really just depends on the epileptologist. We have a lot of patients who are in the same kind of situation that are remote, and it's, it does take, they have to travel, a couple hours to get to the level 4 center. So, usually their epileptologists and the surgeons will work with the patient. The beauty is that your epileptologists can now see that data remotely. So if you think about it, if a patient was started on a new medication and they're, have to travel 3 hours away, the doctor before the RNS would not have any information on what was going on. Now, with the RNS system, if they decided to make a change perhaps to medication, or the patient said, hey, I had a flurry of seizures, now the doctor can say, oh, I see what's going on. Yes, maybe you need to make a change to your medication. Maybe we need to increase it. Or yes, maybe we do need to have you come in. So it actually provides a little bit of a safety net and reassurance for that patient and for that physician to kind of coordinate their care I think in a little bit more efficient manner. Dr. Schwalb, any thoughts on that?
I'm sorry, I was distracted for 1 second. Could you repeat that?
Yeah, so I guess how often do you see your patients, post-op?
Very infrequent.
Yeah.
Yeah, no, we really try and limit it so it's not, burdensome on the patients. I mean, in general, unless there's a problem, we see the patient at 2 weeks. If the patient's far away, we could even have a local primary care doc, see them at 2 weeks just to make sure the wound's healing well and take out any sutures, and then I usually want to see the patient at 6 weeks. And then we try and coordinate things with the epileptologist.
Great. Okay, so it sounds like we don't have any more questions. I'd like to thank Carlo for your insight and for sharing your story about your treatment with the RNS system. And thank you so much, Dr. Schwalb, for sharing your insight and treating patients with the RNS system. I think hopefully everyone has found this very helpful. Dr. I don't know if you have any other last-minute thoughts?
No, I think, I guess the only thing I would say is, I think that people, they see a general neurologist or see an epileptologist out in the community and, they're started on medications and they're able to potentially cut their seizures down significantly, maybe even more than half, and that can make a huge difference in people's lives. But people are still having more than 2 consciousness-altering seizures a year. That's too many. So we're really very aggressive because we know that we can make a huge difference in people's quality of life and even their life in general, preserving life.
Thank you so much. Okay, I think that will wrap up our session for today. All right, thank you so much.
Thanks, everyone.
Thanks.